I'm going to go through this relatively quickly. Hopefully you'll find it interesting. So just to get everybody on the very same page, a couple of reviews of definition. Granulocytes are the root of agranulocytosis, and a granulocyte specifically is a white blood cell that has a granular appearance under a microscope. The broad category of granulocytes can be divided into eosinophils, basophils, and neutrophils. And these specific cell types got their names according to what dye they take up. So eosinophils are stained well with a dye called eosin. Basophils stain well with microscopic dyes that are bases rather than acids. And neutrophils were neutral. They were kind of indifferent to eosin or hematoxylin or other kinds of standard stains. So that's where we get the names. Neutrophil is one type of granulocyte. Neutrophils neutrophils are the overwhelmingly dominant form of granulocytes. So if you look at the total white blood cell count, the biggest portion of that count signal is going to be from the neutrophils. Neutropenia, also known as granulocytopenia, simply refers to a deficiency or a relative paucity of the neutrophils or the granulocyte, depending upon who's using the term. The customary cutoff for declaring somebody as suffering from neutropenia is 1,500 neutrophils per cubic micrometer of blood. And then we have this condition, the feared condition of agranulocytosis. A means not, or it's a negating prefix. And agranulocytosis simply means the lack of granulocytes. We don't wait for the granulocyte count to go down to 0 before we say somebody is suffering from agranulocytosis. The conventional definition is a drop to 500 neutrophils or granulocytes per cubic micrometer. And the neutropenia and the agranulocytosis are, according to what people tell me about their fears and concerns around clozapine, they loom very high in the concerns that clinicians as well as patients have around clozapine. It turns out surveys actually show that clinicians tend to significantly overestimate the risk of neutropenia and agranulocytosis. And it's probably a much higher number of people in the general public. The overestimation of the occurrence of these side effects is understandable because this is the only psychiatric drug that the FDA has first pulled off the market due to lethality, and second reintroduced it with strong regulations around blood draw. So since there's such attention on drawing blood and not dispensing blood unless you see the white cell count, I think it contributes to the impression that neutropenia or agranulocytosis is a significantly big problem. The data are interesting. I'll make the case that neutropenia is actually, the risk of neutropenia in the first year is less than 1% of cases treated. And after the first year, it's, no, let me back that up. The risk of agranulocytosis in the first year is less than 1%. And after the first year, it drops down to by almost an order of magnitude. Meanwhile, while we tend to get worried a lot about the risks of neutropenia and agranulocytosis from clozapine, every other second-generation antipsychotic drug is capable of causing the exact same thing. So here are reports of neutropenia associated with olanzapine. Here are some reports of neutropenia associated with quetiapine. Here are some reports of neutropenia associated with ziprasidone. Here are some reports of neutropenia associated with aripiprazole. And by the way, these reports of neutropenia also come up with the agranulocytosis complication. And here's the list of reports of hematologic adverse events associated with risperidone or paliperidone. So as the literature review would suggest, neutropenia and agranulocytosis is not unique to clozapine. Nobody's done really formal surveys to get at the question of what precisely is the risk of neutropenia or agranulocytosis from second-generation drugs. But two studies, relatively small in scale, had the somewhat surprising finding, surprising to some, that the risks are the same between every other second-generation drug and with clozapine. So, so note to everybody in the audience, you might want to monitor, pay attention to the white blood cell count in any patient that's receiving a second-generation antipsychotic drug. And I say second-generation because, in fact, the risk of hematologic adverse events is higher with second-generation drugs compared to first-generation drugs. So what exactly is the risk, coming back now to just clozapine as a consideration, what exactly is the risk of agranulocytosis? As I said in the beginning, it's kind of small. The risk of agranulocytosis within the first year of treatment is probably no more than 0.9%. It goes down in some cases, in some estimates, after the first 18 weeks of treatment is when the decline may start. But certainly by the first year of treatment, if you haven't suffered agranulocytosis, then your risk drops down a lot, perhaps to 0.1%. And if a person winds up experiencing agranulocytosis, the risk of that person dying from that complication is about 3 in 100. So if you multiply a 3% risk of mortality from agranulocytosis by an actual risk of agranulocytosis of, say, 1%, then you wind up with an absolute mortality risk of about 3 in 10,000, which isn't a lot, especially when you balance that against the risk of death from suicide in schizophrenia, which is 1 in 10 patients. Consider the fact that clozapine actually reduces suicide risk in schizophrenia, and according to some studies, nearly negates that risk, or at least it brings it down to the population average. And if you do the math, you'll find that we probably are allowing between 5 and 10 people to die from suicide for every one that we may be saving from the mandatory blood monitoring program, to the extent that mandatory blood monitoring is an impediment to people being on clozapine. So the history is understandable how we got to this point. There were some celebrated cases of mortality with the first introduction of clozapine, but I would be one of the group of people that would argue that this focus on blood testing and the regulations around it does protect some people, but it does expose others, I think, to significant harm. In fact, Iceland has kind of done away, actually not kind of, Iceland has in fact done away with mandatory blood testing, finding that the benefits of reduced morbidity and mortality from clozapine is acceptable. Clinicians are still encouraged to monitor white blood cell count, but there aren't these restrictions that you can't get drug if you don't have blood. So the question, so we've established that the risk is there. It's small, but not zero. And if you're the one that has it, it's a big deal. Is there a way that we can prevent it from happening, that we might be able to know in advance who's at risk and do things to prevent it? And the answer is, unfortunately, not a whole lot. There were some genetic screening packages that were on the US market, or on the worldwide market, which would look at a panel of immune antigens. Among the HLA antigens were key in that genetic screening algorithm. And if you were positive on the genetic screen, that did predict high probability of transition to neutropenia. The problem was that a whole lot of neutropenias happened in cases that were negative for the antibody. So the antibody test had high specificity, but low sensitivity. And in the end, it was abandoned and the test is taken off the market. So genetic testing doesn't really do a lot of good prospectively for clinicians to identify at-risk people. And the only other signal that comes out as a possible modifiable risk factor is polypharmacy. Keep in mind that every second-generation antipsychotic drug can have neutropenia risk. So the low-hanging fruit in hypothesis is that clozapine plus other second-generation drugs may increase the risk. There are a couple of demographic factors which are moderately predictive of risk. Both the very young and the very old are at higher risk for neutropenia. Males tend to have a slight advantage, if you will, or a disadvantage. They have a slightly higher risk of neutropenia. Being of Asian or African American ethnicity is a moderate to slight increase of risk. The next bullet point, polypharmacy, about ranitidine and PPIs. Keep in mind, this is with a very small data set. Unfortunately, the data around predicting neutropenia is itself very small, but there have been a couple of studies which suggest that the H2 blocker ranitidine and more consistently the proton pump inhibitors might have an additive effect and increase the risk of neutropenia in clozapine treated patients. And it's not a risk factor for real neutropenia, but there is a diurnal variation in white cell count, and white cell numbers tend to be lower in the morning. So my first recommendation for clinicians who are getting a report that says that your patient has now got a blood neutrophil count of, say, 1,300, is to repeat it, but make sure the patient has the blood draw in the afternoon. Hospitals tend to love to draw blood in the morning, and so you can get a significant number of artifactual mild neutropenias simply by catching it at the morning dip. So what else can we do to prevent? Well, where possible, minimize exposure to other drugs. For the cases of the mild neutropenia, like the case I described, where there's a number of 1,300 or so, if the patient is doing well, many clinicians will add lithium simply to boost white cell count. Lithium by itself isn't going to prevent the process that leads to agranulocytosis. So if a person is in that pathway, they're probably unlikely to rescue them from developing frank agranulocytosis, but it can certainly boost somebody from mild to moderate neutropenia into the acceptable range. And then there is a drug that has gotten several names. The generic one is filgrastim, and it actually stimulates the bone marrow to make neutrophils, and so you can increase neutrophil count that way. If somebody has had, if a clinician has had to discontinue clozapine because of persistent neutropenia or severe or brief but severe neutropenia, then the recommendation is to try to make them well with something else. Unfortunately, clozapine is kind of the drug of last resort, so most of the options have been tried and failed before a person is on clozapine. So it can be a very big challenge to find a non-clozapine alternative which is adequately successful. So in cases where clozapine has had a very clear benefit and where its discontinuation is resulting in a degree of psychosis, which is creating significant impairment or risk of morbidity or mortality, clinicians can reinitiate clozapine, obviously doing so very carefully. And there is certainly a role described in the literature for the use of filgrastim in trying to boost the white cell production to mitigate that risk. The unfortunate thing is if a person then develops agranulocytosis, they will have done agranulocytosis now and shown sort of some resistance to the colony stimulating factors. So it might be a much bigger problem to solve, agranulocytosis in that scenario. But nonetheless, that is to my knowledge, the best we have for trying to prevent outside of simply monitoring. So to summarize, mild neutropenia is relatively common. It may affect as many as 10%, but I mean mild and transient neutropenia. Severe neutropenia is actually quite rare. Neutropenia or severe neutropenia risks may actually be equivalent between clozapine and most of the second generation antipsychotic drugs. And especially for clinicians who are relatively new to clozapine prescribing, there can be a lot of anxiety if a report comes back from the laboratory that says that they are now below 1,500 cells per cubic micrometer. My counsel, as well as I think the advice from most of people who prescribe clozapine more often, don't panic. These things typically resolve. Oftentimes just doing another blood test that week will find that it's resolving. for mild neutropenia. If the patient is making good gains with clozapine, then do consider the use of lithium to boost the numbers so that the patient can continue on a successful drug. So those are the slides and comments I have about that, and I'll go back to